He has been he has been Prof. Mughal has been working in field of surgery for last more than 50 years and has got vast experience. And if I start talking about him, I'll probably have to run one full webinar for him, only for introduction. But apart from his national and international achievements, what I can say is he's one of the greatest surgeons of our time, and we are very lucky to hear some words of wisdom from his vast experience in surgery. So over to Professor Mughal.
Thank you, Ravi, for those kind words. That sounded like an obituary more than anything else, but
Don't say
uh,
that. No.
it's a great pleasure to join this webinar, and I just want to check that my slides are showing. I'm going to go on to full screen. Is that showing all right?
Perfect.
Great stuff. Okay. Um, well, how did I start, running a benign complex upper GI MDT? I started life as a surgeon in the Northwest. In 2011, I was appointed to UCLH. At that time, I'd been a consultant for 22 years already, but when I landed at UCLH, I was suddenly confronted with a whole range of complex conditions that I'd never met before. And so, as has been said, cancer pathways are relatively straightforward, but benign complex disease comes in different guises without guidelines. And there I was in a quite a lonely situation to try and give my best to these very unusual patients. And I started the benign complex MDT meeting there, alternating with Imperial St. Mary's, where Professor Zaninotto was the visiting surgeon. So 1 month we had it at UCLH, the next month at Imperial. And when I finished in the NHS, I moved to Cleveland Clinic, which is a private provider. And by the nature of private provision of medicine in London, it is by definition tertiary service. So I'm going to talk about, the benign complex MDT, upper GI MDT in that context. I'm going to talk about the why, the need gap, the what are the sort of cases that we are discussing, how, structure, process, governance. There is some published evidence on this in this space, so I'll share that, and then really finish with our learning to share with you. Well, to start with, here it is that we've got an increasing range of interventions now. It just used to be surgery many years ago, and now we have a lot of endoscopic and other interventions, third space endoscopy, as the gastroenterologists call it. And you see the procedures listed there, TIF, POEM, G-POEM, Z-POEM, etc. So we have to take these into account when we are deciding what is the best procedure for the patient, and that requires fairly careful thinking. I'm glad that Anthony is joining us. As will become obvious, the GI physiologist is a core and important member of this MDT. And what's happening there is that there is an increasing range of new GI physiology investigations which we need to learn about. And without having a GI physiologist at the MDT, we don't know what is going on. You can't have Anthony in every outpatient clinic that you do. And of course, as the interventions increase, so do the complications. And the fact of the matter is that if your complication rate, despite it being low, if you actually increase the totality of interventions, by definition, you're going to have more problem patients. So we have obviously failed anti-reflux procedures. We are beginning now to see failed TIF operations. They require a particular expertise in revising, as we are finding out, recurrent hiatus hernias, of course, and bariatric procedures. And then there is a range of complex conditions that sort of straddle gastroenterology and surgery, gastroparesis, complex strictures, etc. And of course, as we've said earlier on, cancer has pathways. We know what to do for certain stages of cancer. And here, every patient is different. And therefore, you've got this sort of lack of guidelines. And therefore, the need for an MDT for a complex case who's perhaps undergone 3 or 4 operations is really very necessary. The sort of case mix that we've been sort of dealing with is, first of all, complex scenarios that will be familiar to all of you. Revision surgery is the obvious one, but the diagnostic uncertainty, what exactly is causing the patient's problems? Is it an anatomical problem or is it a functional problem? And there may be an overlap here. So it's to dissect that out. Structural and reflux, so giant complex hiatus hernias, strictures that are particularly difficult to manage, and airways fistulae. I mean, obviously some of these are malignant, but there are nevertheless quite a lot of benign airway fistulae that we deal with. And of course, motility disorders. Again, what is the best treatment for this case of achalasia, gastroparesis? As I said, we now have an interventional gastroenterologist who does GPOM procedures. Should they have that? Should they have dilatation? Should they have a bypass? Things like that. Um, this is our team, and we'll come to this when we come to sort of resources to run these meetings. So the MDT coordinator is, of course, very important to pull everything together. Specialist gastroenterologists and surgeons. So you may have seen in my title slide that we've actually merged the Department of Upper GI Surgery and Upper GI Gastroenterology into an integrated foregut service. And so, as far as we're concerned, gastroenterologists who do intervention in this space, basically that's another form of surgery. And so it is one department. GI physiologists like Anthony. So Anthony is a member of our team. Neurogastroenterologists are absolutely fundamental. There are too few of them, I realize that, but we are very fortunate that we've got one. A dedicated upper GI radiologist is important, CNS to support patients, and we also have a dietitian as part of our team. This is our process. We have a monthly meeting between 6 and 7 p.m. So it's outside the normal working hours. It's a virtual platform like this. Most MDTs now run, on virtual platforms, and it can run very well and allow people to join from different locations. And we tend to keep to about 6 cases maximum because some of these cases are very difficult. And we've seen this with cancer MDTs. You can load the meeting with all the cases that have come that week, and you find out that as you finish the meeting, there's little time left, and the most complex case you have to discuss falls at that time. And so it is not only important to have, these meetings, but important to make sure you got time to devote to these cases. So we do a little bit of preparation before the meeting to make sure that this is sorted out, and any extra cases really need to be discussed in extra time. It's properly chaired and minuted like any other MDT. We capture the outcomes straight after the meeting, and these are generated and disseminated within 24 hours. For us, the benefits are quite clear. I mean, for the patient, this is a great advantage. In fact, when we tell our patients that, we're going to put them through an MDT, they've often been to see several different clinicians over the years, and they think it's a fantastic idea that you've got these clinicians gathered in one space, actually sharing the information in real time rather than, sort of one after another. And that they will get a consensus for the recommendations for treatment. And this reduces these repeated and sequential outpatient appointments. Now I will go and send you to this person. Now I'll go and send you to another person, and duplicating investigations. For the team, all of you working in this area will know that, this benign complex space can be a very lonely place because, the patient that you've got, you may never have seen a case with that particular mix of complexities. So sharing the decision in a meeting where others can help you to come to a sort of recommendation for it is a great thing to have. So it's great for the team. And it's a huge amount of learning and CME for us. So we've learned so much from Anthony about the right test to do at the right time. We learn from each other, we learn from each other's cases. And really, it's fantastic CME for the whole team and for trainees as well who attend. And the other thing that I found, certainly when I sort of landed at UCLH, I went there in 2011, 2012. We set up the MDT. And what happened as this sort of MDT philosophy developed and more people from outside UCLH were referring patients for discussion, it then led to more referrals for actually surgery. And one of the things that we have in our MDT is that if we have made a recommendation and this is followed up, we like the follow up at the next MDT or whenever it comes up. So somebody can tell us that this was recommended by the MDT, this is what we did or didn't do, and this was the outcome. So it's sort of a feedback loop in there. What was the impact of the decisions we made? So I think that is also a very important function of the MDT. Well, it's not a paper. It's actually, I think it was a poster or an abstract in the BGS. A study from Norwich, which looked at 74 patients discussed in an upper GI MDT. Now, interestingly, here, the majority were referred by surgeons. In our MDT, it's sort of 50-50. So a lot of our gastroenterologists will refer patients. Most of them were discussions around anti-reflux surgery. And as you can imagine, there were a lot of patients, nearly half the patients who had previous surgery. And the interesting thing is that more than half the patients, the discussions resulted in a change in management. So in a quarter, it was for further investigation. 16% referral to specialist services and 24%, 21% listed for surgery. And interestingly, and you'll see that in the next sort of bit of evidence I'm going to present on our own experience, that rather than the MDT recommending more surgery, it tends to be de-escalation, which actually is probably not a bad thing in somebody who's had 5 operations already and you are tempted to do yet another one. Does the patient really need one, or do they need something else? So this is from an Australian study with a larger number of patients, 104 patients. And you can see here a much larger percentage of patients where the management was changed. Further investigations were recommended or referrals to an additional service. And these are the direction of treatment changes, either think about medical ways of managing this condition or endoscopic sort of treatments, and certainly surgical de-escalation, as they put it in 58% of cases. So don't operate again. Think of other ways of dealing with this. Implementation and governance. So there are issues here. We are obviously all constrained with time. And so there are job plans, administrative support that needs to be taken into account. How will people be able to attend these meetings and that we can have a core attendance. There's no formal funding model. The cancer meetings, of course, happen in working time. They're in job plans, but a lot of benign complex or benign MDTs really do not have a statutory basis, and therefore there is no funding model. There can be sort of these gaps in expertise. Not everybody is as fortunate as we are to have Anthony attending, to have a neurogastroenterologist as part of our MDT. I've recognized that some people do not have access to expertise in these areas. Governance is an issue, particularly in the tertiary sort of MDTs. So a lot of our patients will be referred from outside our sort of medical jurisdiction. So it's not patient from our trust. Some of the patients are from abroad, and you have to be careful about providing advice outside your jurisdiction. So if we are got a patient referred to us from Qatar for an MDT discussion, it is very important that we actually say that this is our advice to the referring clinician in Qatar to then take into account what we're recommending, but the decision is theirs, not ours. So the sort of governance really falls into the sort of referring clinician rather than us. If we see the patient in London and see them in the outpatient clinic, then that is our recommendation. We've discussed it with the patient, but you have to be careful about this cross-institution regulatory framework. So the key takeaways are that I certainly have no doubt in my sort of now 15-year experience with this that they are beneficial to patients, to teams, and to institutions. As I said, we get now referrals from all over the place. It has opened up a new chapter personally for me because I now work with surgeons at Great Ormond Street Hospital for Sick Children because of their patients with atresia who become adults and at that sort of threshold they still may have some problems that need some advice. So that's opened up all sorts of referral streams. The challenges, as I've said, is the availability of expertise, core expertise, job plans, admin support, and as I've said, just got to be careful about the governance side of things. Thank you.
Thank you, Professor. It was very comprehensive talk covering almost every aspect of complex benign MDT, and I have personally benefited from your MDTs. So it is definitely good to have this. We are running slightly behind, so without taking much time, I'll introduce the next speaker, Asma Sultana, who is a good colleague working in neighboring hospitals. And when we started our MDT, we started including every benign case, which encompasses hiatal surgery and gallbladders. Thankfully, Asma started separate benign HPB surgery, and that took half the workload away from us. She's very experienced surgeon, trained in Edinburgh, Birmingham, and Adelaide, and is currently HPB CRG chair in our region, and has been instrumental in setting up HPB MDT in the region. So over to you, Asma. Asma.
Good evening, everyone. Good evening, everyone. I apologize. I don't know why my video is not working, so apologies for that, but I will get started with sharing my screen. Thank you, Ravi, for the invite and the kind introduction. And it's like very humbling to follow an icon like Professor Mughal. So, oh gosh, why is just give me a second. My slides have disappeared. Um, do, 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 do. Ravi, my slides have disappeared. I think I'm going to log out and log back in. So in the interest of time, why don't you go to the next speaker?
Raj.
Yeah.
Okay. Yeah, Raj is my very good colleague working with me for last about 6 years, and he has huge experience of hiatal surgery, more than 100 to 200 cases. But even with that experience, he sometimes used to struggle, and he has helped me to set up benign MDT in our hospital. So over to you, Raj.
Thanks, Professor Zade. Thanks for your kind introduction. I'm going to share the screen now.
Yeah.
Can you see the screen?
Yes, yeah.
Thanks for this opportunity. I'm just going to go through the process in which we went through why we needed the MDT in our institution. After listening to Professor Mughal's talk, I think it's pretty apparent like there is a lot to learn from him, and similarly from our senior team. And this cross learning will be facilitated by setting up an MDT, which is a semi-formal kind of process. So why did we needed this MDT locally? We have been a tertiary center for over a decade, and there have been 6 senior cancer surgeons and Professor Date. And there have been a recent expansion in the last 5 years or so where our pool of consultants has increased by adding 4 benign upper GI surgeons. So as you could imagine, the workload increased and the patients' referrals have increased. And the complexity of the patients who have been referred to us, that has increased. And it is pretty much not that every patients are straightforward. And we have been trained by Professor Date and our colleagues, like we are dealing with a lifestyle modifying surgery rather than a life saving surgery. Bearing that in mind, the room for error in such patients are pretty low, is very less. Hence, there have been a constant referral to the senior colleagues to seek their opinion, and always in touch with them. They are pretty helpful. We had a lot of over the coffee kind of discussions, but they are not translated or they are not documented. And there is always a bias from the referrer as well. And the patients did make some complaints because they have to wait long for the appointments with the senior colleagues, and that it helped. And we did felt like with the expansion of the consultant pool, setting up an MDT as a process will help in team building and cross learning between us. And pre-launch, the things that we consider was there was wider discussion with to identify the stakeholders, so who to include. So we are pretty sure that the MDT should involve obviously upper GI surgeons, the gastroenterologist, and GI physiologist. There are 2 contentious. One is a radiologist and the dietitians. And the radiologist, we thought whether we should get them.
Raj, your slides are not moving.
Is it moving now? Or?
No, you're not on slideshow, basically. That's maybe the problem.
I'm on the slideshow. Is
Not
a
on,
second?
just move them on the panel on the left-hand side. Yeah. Yeah. Yeah, we can see the next ones. Yeah.
So I didn't make a full screen. Unfortunately, it didn't work. So apologies for that. We had a wider discussion. The 2 people were not sure whether should we involve the radiologist as an ad hoc basis or on a regular part of the team. And secondly, about the dietitian, should we include them as well? Because most of these patients, the presence of dysphagia is a functional issue, whether they will add quite a lot of input to it. And finally, we decided to leave out the dietitian. The reason being, they have their own MDT, and our benign MDT may be overwhelmed by bringing in another complex group subset of patients into it. And we discussed regarding the timing, how do we do it, how frequently do we need it. So we thought initially we'll start as a monthly. Depending on the caseload, we can move it to every other month or a quarterly, and suitable day as well. So we had to explore which day will be suitable for us. And we have our cancer MDT on Fridays starting from 9 o'clock. Therefore, we scheduled our benign MDT an hour before to maximize the participation of upper GI team. And when the discussion went up to the managers, there was some resistance regarding the funding. So how do we allocate the time, whether this could be job planned primarily. And this is across the board from the gastroenterologist side as well. And always there is a self-doubt whether this is a viable project, whether this would take off. And further on, we had an excellent opportunity. And again, thanks to Professor Mughal, he allowed us to observe Cleveland benign MDT, which we did like few months before launching our own MDT. That was an eye opener. And the way that MDT was set up and the complexity of the patient discussed and the reasonable outcomes which we feel that always been achieved, it was a real eye opener. And that kind of set us up on a path to how to run our MDT. So we based our MDT predominantly based on Cleveland's model with very sparse funding though. And our activities finally been agreed to be job planned by our management team as well. So our contributors in our MDT is upper GI surgeons, gastroenterologists, GI radiologists, and physiologists. Unfortunately, we don't have a nurse specialist who I think will play a pivotal role, but there's no funding available, unfortunately. And secondly, probably we may need a secretarial staff on board during this meeting. Currently, it's Professor Date's secretary who is helping us with running the show. So when we started initially in 2023, it was Professor Mohal who presided over our first few MDTs and offering us an oversight. And our initial referral pathway was simple. Anybody who needs the patient to be reviewed by the MDT refers the patients to our upper GI secretaries, and they populate our agenda and we discuss. And we did advertise to our secondary care, our feeding hospitals, and the upper GI surgeons from there did participate. Having worked as a team in the Lancashire Teaching Hospital, like we are a well-gelled team, and the unit acts together, and most of decisions are patient-centered. That includes a gastroenterologist as well. So holistically, our aim was pretty much straightforward to improve the patient care. So far, for the last 3 years, we have had around 8 meetings every year, and we discuss around 6 to 7 patients in a meeting. And we have improved our exclusion criteria, as highlighted by Professor Date, where we have excluded discussing the HPB-related issues or the gallstone-related issues. And we have improved on vetting as well along the same. And I just want to go through few examples, which I think it would have taken quite a lot of time if it has been a discussion between an individual surgeon and a gastroenterologist. There's an emergency patient who had a bore house perforation, who had a T-tube repair with an ongoing leak. And then the leak did not stop. He had a stent insertion. There was a migration of stent. The issue was there was a stricture at the proximal end of the stent where the guide wire was non-negotiable. I think MDT happened at the right time for this patient. And with the gastroenterologist and the radiologist on the board, the interventional radiologist on the board, the decision was made to do a retrograde stenting through a venting gastrostomy. If I reflect on this particular patient, if I am the duty surgeon organizing a discussion between the gastroenterologist and the interventional radiologist and the GA radiologist, it would have taken at least a week or two for me to arrive any conclusive decision and also to arrive at working at a reasonable time frame as well. I think in this patient, the MDT helped us to achieve the outcome to be achieved in a reasonable time frame. And the second patient is one of the other common recurrent theme, like which we are encountering now. This is OG junctional obstruction. The patient with dysphagia, with a severe reflux, on PPIs, which is not responding. The manometry is showing OG junctional obstruction. Tried all medications and it hasn't worked. Again, time and forth, we did manage the patient. And when we refer to the gastroenterologist just say the barium swallow looks normal and the manometry shows OG junction obstruction. There's no further input required, and off you go. But when we are on the board as a team, I think the outcome did change. And this patient ended up in having a dilatation following a timed barium swallow. How this is not applicable for every patient with a OG junctional obstruction. And hence the role of MDT is very vital, where it helps to skim through and help us to patient tailored approach for every patient with regards to the provision of treatment. And lastly, there's another patient with an achalasia who had a esophageal diverticula. Patient is keen for surgery. Anesthetists felt like he's high risk for any surgical procedure. And therefore, the MDT discussion was made. The poem is pretty tricky for this patient, as the distal esophagus was pretty tortuous, and which is complicated by the fact the esophageal diverticula lies just on the lower end of the esophagus. And the potential risks were all were confirmed, and it was agreed the patient was seen in kind of a joint setup and further on moved to a balloon dilatation. These are the few patients that I could think of. However, there are quite a lot of complex patients where we went for third redo for a reflux disease and second redo where the patient expectation is way off, where we have denied surgery with the backing of MDT, which is helps us. Secondly, I shouldn't, should I say accomplishments? I'm not sure. But we are receiving more tertiary referrals than we are receiving more referrals for complex patients, which in itself to me is an achievement, which demonstrates the ongoing work that is happening. And it has streamlined the care pathway for most of the patients. Whereas a team, we agree the way to move forward in managing such complex patients. And it has definitely helped in as a team building exercise with the gastro and the radiologist. And we work better now. Moving forward, I think, is just continuing with the ongoing engagement with the gastroenterologist, the radiologist, and the GI physiologist in particular. And Professor Date has developed a tool of getting the patient's opinion on assessing what would they like to see their life as after the operation, to put it down in black and white. And we would like to incorporate that into the MDT discussion part so that indirectly lead to the patient participation. And one of our colleague, Mr. Nandi, is developing an online referral form for that. And we are in the process of auditing our outcomes as well. I think that's in a nutshell. Thank you. Thanks.
Okay, thank you, Raj. Thank you for giving us some overview of the difficulties encountered in establishing benign MDT and also showing the examples. Probably these difficulties are at different level in different institutes, and it just gives the message that we should all have MDTs to basically that should suit our own needs. And we'll pass it on to Asma and move on. I can see you, Asma, now on the screen, so hopefully your screen should be working. You're muted.
Hello there. Yes. Hopefully second time lucky. Let me just share my screen. I really apologize. It certainly worked when we did our slideshow. Um, I really don't know why it is not, it just refuses to come onto the window that I was sharing before. You know what I'm going to do? I'm going to send my slides to Sarvajit, and please go on with the next talk. I'm really sorry about this.
Send it to probably she. Okay, send it to her. Yeah. Do you want to move on to the next speaker or you want to wait? I think if it's going to take time, we can move on to the.
Yeah, I think please move on to the next speaker because, yeah.
Yeah. Okay. I'm not sure who is going to speak next, whether it's Prof. Dhar or Prof. Dr. Barber. Both of them are from Middlesbrough. Prof. Dhar is a consultant luminal gastroenterologist and professor of medicine and past chair of education of BSG and current deputy guideline lead for therapeutic endoscopy with interest in upper GI and endobariatrics. So shall we introduce call Professor Dhar first and then Dr. Barber?
Good evening. Thank you very much for the kind invitation. I hope you can hear me.
Yes.
I think my colleague Jamie has not yet signed in. I can't see him.
We can.
Yeah. Can you see him?
Yes.
I am here.
Okay. I think, that's good. Jamie, hi. I think what we'll do is Jamie will go first. He will give you some reflections on our interaction with surgeons in a very collaborative and productive way. And I will then show you a few cases where Achalasia MDT, which is a regional MDT in the Northeast, has helped make some decisions which would have been otherwise without the MDT. So, Jamie, please go ahead.
So hopefully you can see that. Thank you for asking me to come along and talk. I work with Professor Dar and Professor Vishwanath on our poem development in the Northeast. And I'm going to talk about the MDT, just like everyone has already. My take is very much an endoscopy take on it. That's what I do. I'm a gastroenterologist, and I do ESD and I do poems. So, and we develop poemed in the Northeast, but I'll talk about that in a minute. But I'll just run through these slides. So, what I'm going to talk about is my experience in the complex colorectal polyp field rather than the upper GI. But I think that does have relevance to upper GI. And there is an evidence base in the complex polyp MDT in terms of whether the outcomes improve with MDTs. And I'll talk about that. And then developing and innovating new procedures and applications. And this is really the poem procedure that we've developed with the help of a wider team, and how important the MDT is for us in the Northeast. So when I became a gastroenterologist or consultant back in 2008, I remember someone saying, why don't you do all the colonic polyps? And I sort of said, yeah, okay, I could do that. And I work in a district general hospital. So it's not a tertiary referral center, but it's a big enough place. So I did that, and from 2008 onwards, the referrals, just like previous speakers have said, start growing. And if you stand up and say, I've got an interest in this thing, then people will say, oh, brilliant. Can you sort this out? But you've got to provide a good service. And when you start, you're not providing as good a service as you do 10 years down the line, or even 20. So you've got to reflect and develop And that's what I did. And I published how I developed an EMR service in a DGH, and you know, my outcomes became, it did not to start with, but it became comparable to published series of EMRs. So you know, and that was achieved by collaborative working between physicians, surgeons, nursing colleagues, to support the training of and subsequent referral to designated therapeutic endoscopist specialized in this technique. So you do, it is really satisfying creating a service, and making it something that people refer to. And as things changed over the years, ESD came in, and I remember thinking, now that is what we need to do. And I spent 3.5 years traveling to Cardiff on a fortnightly basis to work with Sunil Dalwani. And Paul O'Toole and myself, Noriko Suzuki, and Sunil co-authored this paper that was published in 2021 about learning ESD. And you'll all perhaps recognize this rather lovely picture. And it's something whereby you've got a plan to develop something. You think, oh, it probably won't be too difficult. I'm gonna do this. But actually, in reality, you've got a long journey to get to the finish where you want to be. And that's often the case with complex surgery, complex endoscopy. And, you've got to be safe, and you've got to be, always have the patient in the center of your ideas. And the benefit of the MDT is that you can actually do that if you do it carefully enough. And the training pathway in ESD, very much like POEM, is you observe, you practice on models, you have supervised hands-on practice on patients, and then you can do remote supervision hands-on patients with a digital platform where one of your colleagues, an expert in, say, UCL, can be watching the procedure that you're doing in Gateshead or Middlesbrough, and they can actually give you some advice during the procedure. So it's a remote supervision, but it's extremely useful way of proctoring. And then you start becoming independent, but you need to continue to reflect, audit, and intermittent upskilling with experts. And then finally, you start mentoring others. And this happens over sort of 10 or 15 years. But that's the way to perform high quality, safe procedures. And my audit is interesting because over the years, you can see in ESD terms steadily increasing. From 2016, I did not that many, 3, but it started increasing. And this will be the same, I guess, for your complex surgery type things. And the better you get, the more you get referred. And then you start getting scarred lesions in the colorectum, and that is difficult when they've had a few goes at them with EMR. And of course, in the colon, just like the stomach and the esophagus, what looks benign sometimes isn't benign and actually can be cancerous. And this column here shows how many cancers are turning up. And it's on average about 10%, 10 to 12%. And it's fairly steady through the years. And we know that that's the case with complex colorectal polyps. And it'll be the same for complex upper GI lesions that look benign, but actually turn out to be cancer. But that's how we manage early cancer, is by offering optimal treatment, which is en bloc resection, not piecemeal, and also we have a R0 quality marker. And as you can see in 16, I was not so good, but gradually, steadily, my R0 rate is improving. And actually, and thankfully, touch wood, I've had no salvage surgery required throughout my whole career, and that's probably going to change at some stage. But if you look at the rectal and colonic, rectal, as you probably know, is pretty forgiving because it's not above the peritonal reflection. But as you go above the peritonal reflection and you start taking off benign and early cancerous lesions above the peritonal reflection, you start increasing the risk. And the actual risk is about between 4 and 7% perforation. But these perforations are extremely small because you've got a tiny knife and very high magnification, and you're cutting around these polyps very carefully. But that's colonic ESD. And then for the evidence of why MDTs or do MDTs make a difference, are we just enjoying chatting with each other and and feeling good about it, and actually a single operator might be just as good? Well, the evidence that we've got, and we saw some evidence before, was this, and this is back in 2023, and Jodie Parker, who's a surgeon, took or had a look at 2,192 complex polyps over 6 MDTs with Cardiff and Leeds and London and Gateshead, and Durham Darlington. And what was interesting is endoscopy therapy for these lesions, conservative management, colorectal resection, transanal surgery combined. That's all fine. But the key take-home message is that the number of primary colonic resections decreased over the study period without a reciprocal increase in secondary procedures or recurrence. So because of the MDT, as far as we can tell, the number of surgical resections has decreased. And so more of these people are getting organ-sparing resections, which is without any secondary, worsening of their situation. And the median length of stay of endoscopy procedures was 0, or 0 days. Most of them was a day case. For surgical resections, obviously, it's a bit more. And again, malignancy nearly 10%. So it's that's the benign lesions. And multidisciplinary team management of complex polyps is safe and effective. Standardization of organization and quality monitoring is needed to continue positive effects on outcomes and services. So that's the evidence that we've got. Now moving on to upper GI stuff, benign, just like everybody's talking about. We developed POEM in the Northern region from about 2019, and Vish has and Anjan have fantastic people to work with, and without Vish, to be honest, we wouldn't have a POEM service, because he's very, very forward thinking and very open to new techniques. That's not the case for many people in the UK who do what he does. So my hat goes off to Vish, and Anjan's brilliant at interpreting manometry, and that is not easy. And I'd just like to finish by saying we became independent practitioners from novices, and we had different skill sets. So I had ESD skills, Anjan had therapeutic upper GI endoscopy skills. Vish has obviously got a lot of myotomy skills with his work doing Heller's, and obviously the pre and the post management is hugely important. And we reflected a lot on our learning and how we can improve it, and we benefited hugely from the trainers that came up, took their time to come up and supervise us, both in person and also remotely. And this is just a picture that I think really encapsulates MDT, I guess. We as a core team doing the procedure have a physiology MDT every month, and that's a vital. We so benefit from our physiology colleagues, because we need the manometry to be interpreted, and it is very variable. How you stress the patient in order to perform manometry is a real knack. We're very lucky to have national experts and international experts reviewing really complex manometry about what to do about it. We have some brilliant trainers that have come up. We have the theatre team in Middlesbrough, and all of this is wrapping around our patient, and that's why we feel that our patient gets a really good deal, and that's why we feel we can upskill steadily. So we weren't experts when we started, but we went cautiously and used everybody's input effectively. And then, of course, you've got to have the referring physicians referring in. You've got to have the ICB financing, and the regional network as well recommended our pathway. So I'd say that that's a really successful way of looking at MDTs and team working, and we benefit from that. And so I just finish with, I think it's an essential part of patient care. It gives the best treatment for patients. It supports innovation and minimally invasive surgery and endoscopy. And it's best for yourselves as well as clinicians, because it, as people have already mentioned, it gives you support, it gives you insight, it gives you wisdom from colleagues, and it makes you not go to places where you'd really rather not be. So thanks very much.
Okay. Thank you, Jamie, for giving your overview of various MDTs and enlightening us with colonic polyps as well, which we are not very used to.
Yeah.
While we are waiting, can I ask Sarvajit, we are running slightly behind. Is it 3 speakers and 20 minutes left? We'll let Asma start off, and if you can extend the time by 10 minutes, it will be really useful. Asma, you want to get started, please?
Yep. Thank you. I'll just tell next slide, sir, when I'm ready. Yeah, thank you so much. Third time lucky. I'm Asma Sultana. I think Ravi's already introduced me. Without much ado, I'll just go into the next slide. Next slide, please, sir. Or maybe yeah. So essentially, the idea of starting this benign MDT, and to be honest, I did it along with my then newly appointed gastroenterology consultant colleague, Mo Shabika. So I think essentially we felt that for the benign conditions, pancreatitis, complex gallbladder conditions, we didn't really have a forum. And some of these were creeping into the regional HPB cancer MDT and adding to the already immense cancer workload. And we really needed to downsize the cancer MDT and have a forum. And we wanted something that was consensus driven and where we could have timely interventions. The days of pancreatitis being managed solely by surgeons has moved away, and I think a lot of it is done by gastroenterologists. And many of these patients sort of come to us, have their procedures done with gastroenterology, and sometimes it's just having the dialogue of when can we do our repeat necrosectomies, when do we stop? And last but not least, we had our EUSs for which we had no forum. At the time when we set up this MDT, we had the Friday Cancer MDT and a Wednesday afternoon ERCP MDT. But for those patients that needed endoscopic ultrasound, whether they were cancer or non-cancer, they were a bit of an orphaned lot, and there was no forum to discuss these patients. And those were our triggers to develop this benign MDT. Next slide, please. So the outline of my talk is going to be: how did we establish this service? What resources did we use? How did we grow? What did we achieve? And what were the little stumbling blocks along the way and how we surmounted them? Next slide, please. So we first spoke first, and we felt that what we needed was have an online form that is easily accessible. So all those people in the trust, this particular form is there on SharePoint, where essentially the benign MDT is done every Wednesday, and there was a method to that. The idea was that if the benign MDT gets done by Wednesday lunchtime, then the closing for any potential cancer that accidentally came up or was picked up could move onto the same week's cancer MDT. So this was a midweek MDT. And another reason was that we already had staffing, and most of us had times within our job plan to attend the ERCP MDT that happens on Wednesdays from 12:30 to 2 o'clock. So we just felt we'd start the MDT a bit earlier, do the benign, and move into the ERCP MDT. For those people from outside the trust, if they couldn't access the database or the requests, there was also an um, email address that is sort of a generic email address to which the discussions and requests can be sent to. Next slide, please. In terms of resources, we had surgeons already attending the ERCP MDT. We had gastroenterologists. So those two were not difficult. The admin staff, we just essentially borrowed from the ERCP MDT. And I think when we started off, a lot of it was based on enthusiasm and goodwill. I think our difficulty was radiologists. Radiologists, there are lesser number of species compared to surgeons and gastroenterologists, and getting their time was difficult, but eventually we prevailed on our HPB radiologists to spare between half an hour to 1 hour of their time on Wednesdays to come in and link in and look at images on the hoof. Unlike the cancer MDT, where our radiologists have designated time to actually prep in advance, this was going to be, we'll run the MDT and you look at the scans as we're running the MDT. Next slide, please. So we set about the meeting structure on Teams. So it's an online meeting. We don't need a dedicated room. We launched the benign HPV MDT on the 8th of November, 2023. So we've been running it for 2 years now. And any referrer is welcome to join our team's MDT. We present our cases. The team of gastroenterologists, surgeons, radiologists, we basically talk about, what's the best way of going about things, endoscopic, surgical, or just wait and watch. And we right away, our admin staff, it's an online entry. We can see what the outcomes are. The entry is made, and then the MDT chair checks all the entries, and the admin staff disseminated it by sending out emails the very same day. And there are assigned responsibilities of who actions it. Obviously, if there's any endoscopic procedure, there's a vetting of when the procedure happens. If it's any surgical procedure, we either decide whether we're seeing in clinic or we decide in whose list the patient's going to get listed. So there is a plan at the end of that meeting. Next slide, please. And these are our common conditions that we see. A lot of pancreatic pathology, acute and chronic pancreatitis, the autoimmune pancreatitis. We started doing pancreatic cysts, but because our radiologists can't look at several scans on the hoof, we've taken that back to the cancer MDT. So, while ideally we'd like to do it, at this moment, our radiologists don't have the capacity. Then we deal with the complex gallbladder pathology, the perforated gallbladders, the Mirizzi syndrome, the benign biliary strictures. If we're not certain, the patient goes to the cancer MDT. Now, the cancer MDT is happy, then the patient will come back to the benign MDT. Obviously, the bugbear of us surgeons, the postoperative bile leaks and any potential sphincter of body dysfunction. And the complex CBD stones, to be honest, we have a bit of overlap because the ERCP MDT also runs, but I think the regional referrals get facilitated through the benign MDT. And We also deal with liver cysts and then liver incidentalomas such as FNHS, the benign adenomas, unless there is uncertainty, in which case they go to the cancer MDT and get followed up in the benign MDT. So that's the range that we see. Next slide, please. And I quickly looked at, how was our breakdown? We had about 34 patients in 2023 that we discussed when we first started off. And just like happens with any MDT, we're growing year on year. In the 12 months of 2024, we discussed 229 patients. And in just about 11 months, we've discussed 244 patients. Next slide, please. And this is sort of in terms of the distribution across the different hospitals. The majority of our referrals, interestingly, come from University Hospital Morecambe Bay Trust, and they referred about 213 patients across the 523 that we have discussed so far. And then comes ELHT, our own local hospital, which had 213 referrals. And we had a smaller proportion from Lancashire Teaching Hospitals and Blackpool Teaching Hospitals. But this may not be truly reflective because sometimes our colleagues from there speak to us and then we put the patients on the MDT. Next slide, please. Now, in terms of what are we doing well? If you just click on the button, please, sir. Yeah. And keep clicking so I get all of them on. Obviously, we're growing. And we're doing pretty well in terms of our criteria because just about 7% of all the referrals needed to go to the cancer MDT. The vast majority are, quite correctly coming to the benign MDT. We have strong referral pathways for benign conditions now, and we have escalation protocols. And this has sort of reduced our time. I think that's disappeared off the screen for me, but it's reduced the time for outpatient clinics, whether they are HPB clinics for the surgeons or the pancreatic clinic run by Mo Shabika and his gastroenterology colleagues. And that in turn also means that our outpatient waiting time from endoscopy procedures is also sorted. It's far reduced because it's triaging right at the end of the MDT. And effectively, this means reduced readmissions for patients. The areas that were a bit of an uphill task, we won some, we haven't won some. We found as we kept increasingly doing the MDT and the referrals come in, it's, the coordination of these procedures of EUSs and ERCPs, we really felt the need for a clinical nurse specialist who was focused on organizing these procedures and in particular liaising, especially if the patient was not in-house. And in May 2025, Jasmine Russell got appointed as the EUS ERCP specialist nurse, and she helps coordinate these procedures across both non-cancer as well as cancerous conditions. The challenge with the radiologist time remains, so that bit will probably need a bit more of time and work. Thank you. Next slide. Obviously, I cannot, finish this without acknowledging a whole host of people who are responsible for running this service, starting it off and running it. We've got 4 HPB surgeons, 2 who do cancers, 2 who do benign conditions, so we can complement and make sure that we cover the MDT. Previous slide, please. We've got 3 gastroenterologists who all perform EUSs. The primary HPB radiologist is Dr. Nicholson, but Dr. Ali steps in when Dr. Nicholson can't make it. I mentioned about Jasmine. Vicky is a RDS nurse who feeds in the surgical patients, specifically the cancer patients. And Ismail and Andrea, the gastroenterology staff, who sort of do very much of the admin, but we've got someone from bookings who helps particularly facilitating the outpatient booking procedures. The inpatients get done quickly. It's the outpatients that are the lost tribe. So that's in summary how we set up the MDT and where we're going. Thank you all so much for your attention, and I'm happy to take questions, probably right at the end in the interest of time.
Thanks, Asma. Thank you for your talk. And it was interesting to know that in HPB itself, there are 3 other MDTs, ERCP, pancreatitis, and benign HPB.
Yes.
Now we'll listen to all the clinicians. We'll move on to next speaker, Prof. Anthony Hobson. He is internationally renowned clinical GI scientist and director of Functional Gut Clinic, which is the largest provider of GI physiology services to NHS and private sector. So over to you, Anthony.
Thanks so much. I'll just try and bring my slides up. I'm just going to go through this quite quickly. Just let me know if you can see those slides okay.
Yeah.
Great. So we've been doing MDTs for about 10 years now, and incredibly rewarding, incredibly educational. Even now, the ones that we do with Prof. McGall, as you can imagine, I learn something every week, every month, and they're really rewarding. So if you can set these up, I think you will all find that they're incredibly educational and really collegial. So I think the reason for having a physiologist at the MDT is that we have to take into account the fact that all of these things are interlinked. So the brain, in terms of how we initiate swallowing, how we process sensation, how we regulate behavior, the throat, the esophagus, the stomach, and the midgut are all communicating with each other at all times. And all of these things are generating symptoms. So we just can't look at these things in isolation. And the physiology tests, I always put it akin to, it's not like looking at a car in the showroom, which is endoscopy. It's like taking the car for a drive and seeing what's working. And that's the functional aspect of doing GI physiology testing. And the one elephant in the room as well is the M word, and that's the microbiome. So the microbiome is under assault from most of the surgical and medical interventions that are done, whether these are PPIs, antibiotics, surgical revisions, and quite a lot of the refractory symptoms that you investigate, things like belching, bloating, regurgitation, are the revenge of the microbiome trying to tell you that something's wrong. So in order to get an objective handle on this, you need to do detailed physiology. But it's a kind of bi-directional communication that you need with your physiology department. So if you're thinking of setting one of these up, you have to realize that most GI physiology service are very small. So first of all, it's very important to identify their capabilities, go down to the department, see what's happening locally, and see what is available. Once you've established that, then you need to find what the most effective referral pathway is and the best way to request these tests. It sounds like a simple thing, but actually being able to request the right tests and the right nuance of tests is really important. There has to be a clear communication of your requirements as the referring physician and what questions you need to be answered for the physiologist. If you just put on do pH manometry, someone will do pH manometry. You'll get some numbers back, it won't mean anything. But if you put down this patient has mild dysphagia, worried about whether we should do anti-reflux surgery, whether they've got weak peristalsis, please can you interrogate this? You will get a much more detailed test and you'll get a more detailed report. So keep that communication really clear. You need to give a detailed description of your patient history. This doesn't need to be regurgitated in a separate referral letter. Your last clinic letter is usually sufficient for everything that the clinician needs to triage and do the test properly. Please do highlight any specific or atypical requests that you might have. So if you suspect rumination, please put on there, we suspect rumination, put a meal challenge on there. If you really do want to answer a question, be specific in your referral. In terms of reporting format, if your physiologist just gives you back an automated report with some numbers that mean very little to everyone, push back on that. This is the physiologist needing to engage their brain and not just pressing auto report. Ask for images rather than meaningless group images that you often get. Ask for numbers and ask for interpretation. And this can be done in a kind way, but just say, what does a DCI of 449 mean as opposed to 450? Is this patient getting good bolus clearance? Do they have dysphagia? And try and get everyone's brain engaged in the process. And in terms of the MDT format, when you do get the physiologist involved, give them a few days to try and answer the questions that you want from that MDT so that they can actually pull the screenshots, pull the figures, have a bit of time to do that. I think that's what we do for our MDT meetings is put a couple of slides together because it's not as easy as radiology where you can go to PACS and bring the image up. Quite often you'll have to get a specific screenshot to show an episode of outflow obstruction and so on. So as physiologists, we can do motility testing from the pharynx to the anorectum. So if you've got a specific area you want to test, whether it's gastric emptying, pharyngeal motility, then usually most departments can do this. Reflux testing, it's not just about esophageal reflux, it's about non-acid reflux, it's about gas reflux. We can measure in the throat, we can measure in the stomach. In terms of dysbiosis, we can look at bacterial overgrowth and breath testing. And we can also do things like biofeedback for things like supragastric belching and rumination. So there are some conventional conservative treatments that can be applied. But in the interest of time, I'm going to stop there. And, as I say, I think the physiologists require that kind of communication with the referring physicians in order to get the most out of what we do. There are lots of good technologies available. So, get us involved. Thank you.
Okay. Thank you. Thank you, Anthony, for keeping to time. And it was quite enlightening. And we'll probably need you for our hiatal hernia surgery webinar again. So we'll probably invite you again for that. And we haven't forgotten Professor Dhar. So without much introduction, I would invite Professor Dhar as the last speaker. And thank you, Sarvajit, for allowing us extra time. Oh, you are muted, Professor Dhar. Yeah.
Hi. We're running late, so what I'm going to do is, instead of trying to go through the slideshow, I'm going to just talk about a few things which are particularly relevant for our surgeons in our achalasia MDT. I won't go through showing you the physiology because that's going to take time, but suffice to say that I can give you some examples of uh, patients where having an achalasia MDT has made a real difference. So, one of our patients was a 46-year-old woman who came with a referral for dysphagia, and the gastroenterologist had said that the Eckhart score was 7. The endoscopy was reportedly normal. There was not much resistance at the gastroesophageal junction. And the barium swallow showed a dilated esophagus with poorly coordinated contractions and poor opening of the GOJ. The interpretation of the radiologist is that this would be consistent with achalasia if if everything fitted with the clinical case, and without an MDT and without the physiologist's input and looking at the Klaus plots and the actual high resolution manometry pressure tracings, it probably would have been the case that this patient would have been referred for treatment as achalasia and would have ended up on a surgical list for consideration of laparoscopic hilar myotomy. But when we actually looked at the high resolution manometry, we realized that there was peristalsis in the body. The IRP was raised, but the features were not consistent with an achalasia, and this was very much an esophagogastric junction obstruction. So that for the patient made a complete change to the management plan, and we ended up doing sequential Rigiflex balloon dilatation of 30 millimeters and 35 millimeters for that patient, who then symptomatically improved and was able to eat and drink. So we have seen patients who historically were subjected to conventional manometry, given a diagnosis of achalasia, had laparoscopic hilar myotomy, and after 3 or 4 years have returned back with lack of response and recurrence of symptoms. And when you actually look back, they probably were not achalasia. So what I'd like you to take back as a message is that not all dysphagias and bariums, in the absence of a genuine timed barium swallow, are achalasia. And endoscopy, depending on who's doing the endoscopy, is a poor sort of risk stratifier to say that this is definitely achalasia. We don't use a very structured endoscopic technique of recording a CAR score to define achalasia. A second case that I would like to share with you is of a 64-year-old patient who had dysphagia and regurgitation for about 2 years with some degree of belching but no heartburn, and a barium swallow showed delayed transit of barium through the esophagus with some holdup of barium at 5 minutes. And the high resolution manometry for this patient showed a normal LOS with effective relaxation with an IRP of 12, with largely absent contractility throughout the esophagus on swallowing, even after a rapid drink challenge. And where propagation was observed with rapid drink, it was of very low amplitude with poor amplitude of progression. And the same was seen on a cookie swallow with almost no peristaltic activity. So this, after a discussion at the MDT, was interpreted to be ineffective esophageal peristalsis, and that is a condition that up until probably 5 or 6 years ago wasn't recognized very well, and a lot of these patients were managed as if they had achalasia, and carrying out any form of surgery, either Heller's myotomy or even POEM in these patients would be disastrous. So we need to recognize that interpreting ineffective esophageal peristalsis is really important in patients who present with dysphagia. And the final third one, just in the interest of time, to leave some time for questions, is of a 55-year-old man with chronic back pain who uses opiates for pain, had persistent severe dysphagia with vomiting, retching, regurgitation, and feels like razor blades in the mid sternum. The barium showed diffuse spasm with some corkscrew abnormality, which was interpreted to be diffuse esophageal spasm, or in the old days, it used to be called the jackhammer esophagus. Whereas when we looked at the HRM for this patient, instead of a increased DCI, what we saw was vigorous peristalsis in the body together with a raised IRP, which would be consistent with a type 3 achalasia. And the increased high pressure zone almost went up to about 10 centimeters from the LOS, uh, indicating that if we were to carry out a, um, a POEM procedure for this patient with a short myotomy, it wouldn't resolve the patient's symptoms. Likewise, a laparoscopic Heller myotomy would not achieve the target of resolving the patient's symptoms. So we ended up doing a POEM procedure for this patient with a long myotomy. Just to introduce to everybody that we now are looking to incorporate endoflip into our uh, sort of treatment algorithm so that we can actually look at the distensibility index and the resolution of the waist when we do POEM. Both pre and post POEM, endoflip has been shown to improve the outcomes for POEM procedures. So just to give you a flavor of the three cases which without a good MDT with gastroenterologists, physiologists, and surgeons being in the room would have resulted in a very different outcome for all of these three patients. And it probably gives you a flavor of why an achalasia MDT is really useful if you are going to incorporate POEM into your management of achalasia. So I'll stop there and maybe we'll have 5-7 minutes for some discussion. Thank you very much.
Okay, thank you very much, Prof. Dhar. I was just listening to your talk, very interesting talk and very interesting cases. And while the talks were going on, I was looking at number of MDTs have emerged. We already knew about IBD MDT. Apart from that, we learned about colonic polyps, vascular MDTs, ERCP MDT, pancreatitis MDT, gallbladder and sphincter of Oddi dysfunction, IPMN MDT, POEM MDT, achalasia MDT. So almost every disease we can think of is running through MDT, and that was the reason why we uh, chose this topic for discussion. And it was very interesting discussion. And I think we need to think about time we can give to all these MDTs and how we progress. So I'll hand over to Ashok to handle the questions. And if there are any questions from chat box or question answer.
Sure. Well, first, I'd like to thank all the speakers for giving their time today. I think this has been really fascinating insight on how we can manage benign disease, which I think really does take a backseat to the cancer. I apologize, we've run late, and obviously I think we've not really had much time for questions. And I think what I would like to encourage whoever's with the audience today is that we'll try and field the questions to our speakers over the next few days over our social media accounts. So there's a number of ways you could do this. You can field this via our website. You can also direct message us on Instagram, on X, and on our X accounts and LinkedIn. So there'll be a direct message feature on that. So it's BBUGS UK, and we'll definitely contact our speakers, and hopefully we'll be able to continue this discussion over the next few days. But if I may, I'll probably try to end the meeting with one question which all of our speakers can answer, or whoever wants to take this. So I think all of you have quite eloquently said, talked about the value of a complex benign MDT and of the different subspecialties and specialties that can contribute it, and what the value of each contribution is. But we live in an NHS where cancer really takes a lot of priority, and in terms of job plans, and a lot of our asthma, you were mentioning about radiologist availability, they're MDT'd out. They do prostate MDTs, they do colorectal MDTs, they do gynae MDTs and things like that. Firstly, I'd like to know, how do you get the buy-in to actually contribute to a benign disease MDT? And you also mentioned about goodwill. I think there is a novelty factor when we first start these MDTs and they run for a while. How do you incentivize them to get them to stay when it starts interfering with other aspects of their job plan, other activities and things? And I'd really be interested, because we're trying to start a benign MDT as well. And what we want to do, like some of the speakers here, is have a really functioning one that lasts long into the future for the benefits of patients.
Literally last 2 minutes now. Yeah.
See, maybe I'll take that. For me, for us, it was not so difficult, because I think our buy-in from the very hard to find radiologists was that it will reduce their pressure on the cancer MDT. So I think that was fundamentally the focus, and it would save us, popping into their office and interrupting their work if there was one forum at which we all met, rather than the gastroenterologist go off and ask for the same scan before they do the ERCP that we'd ask when we were shipping the patient. So that was how we did it, and we do it.
I think the other thing to remember is that services that are not adequately resourced and funded will struggle even once they are set up with goodwill. So it is a resource-constrained NHS, but at the end of the day, patients deserve the care that is right for them. And it is what we realized was having patient groups write to trust chief executives and medical directors or clinical directors asking for an integrated pathway of care for benign diseases is often very useful and powerful. We've done this with our benign MDTs, the Ecclesia one, which is a region-wide. There's a single MDT for the whole of the Northeast, covering 3.5 million population. There's a single POEM service. So that is equity and not a postcode lottery. We've done it with endobariatrics as well. There was a huge backlog of 600 patients sitting on a bariatric register waiting for bariatric procedures. And the pivotal thing for us was to get some initial couple of patients done, who then were our patient group. And we got BBC Look North to come and film in our theater. And that just triggered off an interest in managing the huge number of people waiting for bariatric procedures. So we actually didn't take patients directly from GPs. We were trying to manage the workload which was already there in the NHS and people getting frustrated. So often it is patient groups and some degree of sort of profile building, but the message is that it needs to be resourced. Otherwise, goodwill only lasts for the initial sort of year to 18 months. After that, it disappears.
Yeah,
Okay.
I mean,
Final word from Prof. Mughal.
Yeah, very quickly come in just to support everything that people have said about the challenges here. So I think one of the problems that you can run into is that you start off the MDT with great enthusiasm and goodwill, and you find out that by the second or third meeting, people just can't get to the meeting, and then you've got a situation where it started with pomp and circumstance, and you've not been able to deliver because the goodwill doesn't last. So I think it is very important. I would counsel people to make sure that when they start, they've got the resources built in so that it's not just the first meeting where everybody turns up, but the second, third, fourth meeting that you've got quorum. And certainly for radiologists, you need cover. It's not just the radiologist who is your principal radiologist, but somebody else would be able to cover. And lastly, what I would say is that I think there's an issue coming here because recently I've been approached by NHS England. They're doing a big piece of work on job plans, and I was surprised to be contacted about this. I don't work in the NHS anymore apart from an honorary contract, and I thought, why are they contacting me? And they're looking at benign MDTs and the time that benign MDT is consuming from consultant contracts. Now, I think at the moment it's a sort of thinking exercise, but I wouldn't be surprised if something doesn't roll out in terms of what is the sort of party line from the NHS, because they know that they are just increasing in numbers. So in Cleveland Clinic, a private organization, we have 22 benign MDTs. Okay, for neuro, orthopedics, gynae, cardiac, you name it. And but we're a private organization, that brings in work for us. Work is money, and so we fund it. But in the NHS, I see problems.
Okay, you can send them our webinar recording as a proof why it is needed.
Send a message or email with a link to your webinar
Okay,
recording.
thank you. We'll conclude the meeting, and thank you everyone for joining. And thank you, panelists, for your wonderful talks and enlightening us with your views on MDT. Thank you.
Thank you.
Cheers, guys.
Thanks, Sarvajit.